Hello and welcome to this podcast on urinary incontinence. My name is Mohammad Farik Jabir. This podcast will be primarily covering the topic on urinary incontinence in geriatrics. We'll be covering the causes of incontinence, the different types of incontinence, and the evaluation of incontinence as well as the management of it. Starting off with definitions, incontinence is the involuntary loss of urine in sufficient amount or frequency to constitute a social or hygienic problem. It should be worth keeping in mind that in spite of aging being associated with changes in the bladder and urinary tract, which make the elderly person more prone to urinary incontinence, the problem itself shouldn't be considered as a part of aging. Incontinence carries a huge social stigma, reduces the life pace of the patient, mobility, as well as has a massive impact on social and financial burden to carers. Causes of acute reversible causes of urinary incontinence can be remembered by the mnemonic DRIP. That's D for delirium, R for restricted mobility, I for infections, inflammation or impaction, and P for drugs and polyuria. Causes of persistent urinary incontinence can be divided into stress incontinence, urge incontinence, overflow, and functional. Stress is caused due to involuntary loss of urine, usually small amounts with increase in intra-abdominal pressure, and is caused during activities such as coughing, laughing, or exercise. Urge incontinence occurs due to leakage because of inability to delay voiding after the sensation of bladder fullness is perceived. Overflow incontinence occurs when there is leakage of small amounts resulting from mechanical forces on an over-distended bladder or from effects of urinary retention on bladder and sphincter. Functional incontinence occurs when there is leakage associated with inability to toilet because of impairment of cognition and or physical functioning. There could also be environmental barriers such as the inability to access toileting facilities. Evaluation of incontinence involves taking a focused history, looking at the active medical conditions such as CNS disease, diabetes, or congestive heart failure. Medications, especially tube diuretics, must be ruled out. Symptoms should involve looking at the onset and duration, the type of incontinence, whether it's stress, urge, functional, or overflow, frequency, timing and amount of incontinence, and periods of continent voids. It's also worth looking at other urinary tract symptoms such as irritative symptoms such as dysuria, frequency, urgency, and nocturia, voiding difficulties such as hesitancy, slowness or interrupted stream, straining or incomplete bladder emptying. A physical examination should be targeted at assessing mobility, the mental status of the patient, i.e. cognitive function, and possible neurological signs such as Parkinsonism. An abdo examination should be performed looking for any bladder distension, masses, or tenderness. Management primarily involves non-drug therapy. In the case of overflow incontinence, intermittent catheterization may be required. In the case of urge incontinence and functional incontinence, behavioral changes should be advised initially, such as regular toileting, reduced oral fluid intake, the reduced intake of caffeinated beverages, using bedside commodes or urinals. Stress incontinence involves smoking cessation and pelvic floor exercises. And when these sort of non-drug therapies are not sufficient to control incontinence, drugs can be considered such as anticholinergics. Common drugs used are oxybutynin and tolterodine. It is also worth remembering that indwelling catheters or long-term catheters should be considered only after therapies have been exhausted. That's about it for this podcast. And this podcast we've covered the definition of urinary incontinence, the different acute causes of incontinence, the different types of incontinence, the evaluation of incontinence involving a history, examination, and routine lab workups, and the management of urinary incontinence. Thank you and goodbye.